Dexamethasone. It's a synthetic glucocorticoid. Natural glucocorticoids are hormones produced in the adrenal cortex. It's an anti-inflammatory, and it's also an immunosuppressant. We are primarily going to use it for its anti-inflammatory properties, although we may also use it for its glucocorticoid properties in an adrenal crisis. This is how it stacks up compared to other glucocorticoids. Primarily Solumedrol, which is the other choice we have in the field. You can see that it's 25 times more potent when it comes to anti-inflammatory properties. Now we'll talk about what the mineral corticoid and the glucocorticoid means in just a second. But you can also see that its duration is much longer. What you will see is that its mineral corticoid properties are less, and that's because it's synthetic. So again, it's a synthetic glucocorticoid. It has almost no mineral corticoid properties. It has very few side effects, and mineral corticoids help balance fluids and electrolytes, whereas glucocorticoids help balance glucose. So why should we use it? Patients treated by EMS with steroids have shorter ER stays and less chance of hospital admission. This is supported by multiple studies. Patients 6 years and older should be treated with steroids within 1 hour of onset of shortness of breath for best outcomes. So in short, it's good patient care. So here's our protocol. So you run all the way down through the EMR, the EMT. We give them the nebulizers for severe respiratory distress. If they're cyanotic in retractions, we can consider epinephrine IM. We put them on the end tidal. We can consider CPAP, although we want to be careful because of air trapping and possible barotrauma. We want to start an IV, give them some fluids. We want to put them on the cardiac monitor, and there we go. We want to administer either 125 milligrams of Solumedrol or 10 milligrams of Dexamethasone IV. So it's an IV push, single dose, and then we continue down the protocol and we can consider 2 grams of magnesium sulfate IV push over 2 minutes or RSI if needed. And don't forget, if the treatment was initiated by the fire department, you must document the exact dose given in the assessment. So 10 milligrams IV is what we're looking for. Allergic reaction. Again, we follow down through the EMR, the EMT. We give the albuterol treatments, end-tidal. We can give them PO Benadryl if they're able to swallow. We can give them Pepcid if they're able to swallow. We give them their epinephrine. And we come down here. 125 milligrams of Solumedrol or 10 milligrams of Dexamethasone IV, right there. And then we continue on. For patients in anaphylactic shock, mix 1 milligram epinephrine, 1 to 1,000 in 1,000 milliliters, 0.9% normal saline, which makes epinephrine 1 to 100,000, run with 10 drops set at 10 to 30 drops per minute, titrating systolic of 90 millimeters of mercury. So our contraindications: systemic fungal infection or hypersensitivity or allergy. And then we want to be cautious. So we want to administer slowly, and we want to consider diluting in 10 milliliters of 0.9% normal saline. It may cause a local irritation, a burning at the IV site if it's pushed too fast, and it may cause transient nausea and vomiting if it's pushed too fast. So now we're going to talk about the additional uses. So patients in adrenal crisis, such as Addison's disease, may have a crisis kit. Others may not have it with them. The dose is 4 to 6 milligrams IV. These people will be hypoglycemic, hyponatremic, and hyperkalemic. They're salt wasters and potassium retainers. They will require aggressive fluid resuscitation and blood sugar management. The thing is that you can give them as much sugar as you want, but without giving them the dexamethasone, the sugar will just be spilled out of their body and they will not retain it. So as always, if you have any questions, contact me, and I look forward to seeing you in the field.